Hello everybody, this is the part 2 of the brachial plexus video. I know I'm a bit too late, but better late than never. So if you guys haven't watched the part 1, please go and watch the part 1 because this is a continuation of that part. So in this video, we'll be discussing the nerves and some of its clinical application, but not so much in detail because some of these nerves have a lot of detail in it, so I'll try doing a different video for that. So let's just brush up on what we already know. We know about the roots, trunks, divisions, cords, and branches. So we already discussed what nerves take origin where. So this is that rocket looking structure which is very simple to draw, and I've taught you that in the previous video. So let's go into the clinical application of each of these nerves. So starting with the long thoracic nerve, this is a high yield nerve. It's been asked a lot, so let's discuss the long thoracic nerve. Here's about the long thoracic nerve. This nerve takes origin from the C5, C6, C7 root, and it mainly supplies the serratus anterior. So anytime you have a patient with a LTN injury, they'll have difficulty putting their hands over their head or maybe stretching up over a shelf. They might give history of difficulty in combing, and the classical sign that you can see in such a patient is the winging of the scapula. So it can be seen here in this image. Okay, so this is the scapula, and as you can see, this side the LTN has been injured. So as and when the patient pushes against the wall, there will be winging of that particular side, the particular scapula. And here we can see what serratus anterior look like. This is a wing shaped muscle. It's at the side and it takes origin from many ribs. So this is about long thoracic nerve injury. Moving on to the dorsal scapular nerve injury. This here, it takes origin from the C5 root, and what the dorsal scapular nerve does is that it retracts the scapula. Okay, it also supplies. How does it retract the scapula? By rhomboids major and minor. From an exam point of view, there is no particular clinical application, so we won't spend too much time talking about that. Now let's come to the supraspinatus nerve. Supraspinatus nerve basically supplies both the supraspinatus and the infraspinatus, as we can see here. Sorry about that. This is the it's not supraspinatus, it's suprascapular nerve. So the suprascapular nerve supplies both the supraspinatus and the infraspinatus. So this, you can see the nerve here, and it supplies both of these. So the clinical application of this, there's nothing much, but when we abduct the arm, abduction, it is in 3 parts. I'll come to that a little later. So the first 15 degrees of abduction is taken care of by the supraspinatus, and that's all you really need to remember from an exam point of view. Okay, so moving on. We finished our long thoracic nerve, dorsal scapular nerve, and suprascapular nerve. I keep mistaking that. Suprascapular nerve. Okay. Now coming to our lateral pectoral and medial pectoral nerves. They take origin from the lateral and medial cords. About them, they supply one of the most important muscles of the upper of the thorax. They supply the pectoralis major and pectoralis minor. Easiest way to remember pect is that everybody knows the situation of the pectoralis muscle. Just remember how to hug a person. What do we do while hugging? We flex the hand, we adduct, and then we immediately rotate the humerus. Just try doing it yourself and you'll never forget the action of pectoralis. So this is the pectoralis major. it has three origins. It has the clavicular, the sternal, and the costal origin. So every time you want to know about the action of a muscle, this is like a small tip. Always know the origin of the muscle, so it's easier to remember the action. So now imagine I'm pulling it towards the origin. It has three origins. If I'm pulling it towards it, you can imagine a person doing the hugging action, which is, as I said, flexion of the arms, adduction, and then medial rotation of the humerus. So that's about it. If you have a pectoralis injury, obviously you can't do any of these, so there's not any particular application as such. So yeah, moving on to the upper subscapular and the lower subscapular nerves. Okay, so upper and lower subscapular nerves, as its name suggests, they basically supply the subscapularis. There is nothing much to it, it just supplies the subscapularis. Dorsally there is supraspinatus and infraspinatus on the scapula, whereas ventrally there is a subscapularis. So that's all to it. Now coming to another major nerve, which is the thoracodorsal nerve. It is high yield, just like the long thoracic nerve. It's questioned a lot. So about the thoracodorsal nerve, it supplies one major muscle, which is called the latissimus dorsi. I'm sorry about that. Okay. So it supplies the latissimus dorsi. Just remember that a latissimus dorsi is lame. That is the mnemonic we're going to use for latissimus dorsi. That means L stands for lats, A is its adduction function, M medial rotation, and E for extension. If you remember this, you're set. It's very easy. So I'll just show you a picture of what the latissimus dorsi looks like. So this is the latissimus dorsi. As you can see, it's spread out this whole area. So this is about the latissimus dorsi. So these are the functions of it, like we spoke: adduction, medial rotation, and extension. So now coming to the last part of our, the most important part, that is the branches. That is the musculocutaneous nerve, the axillary nerve, radial nerve, median nerve, and ulnar nerve. And our mnemonic, if you guys remember, was MARMO. Okay, so that is it. Starting with M, that is musculocutaneous nerve. Very simple. All we have to remember is that musculocutaneous nerve is like the news channel, BBC. So how do we remember that? Just remember that BBC is one of the most famous news channels, all muscular. It's basically the jock of all TV channels. Okay, I don't know how else to make you remember that. So BBC, why? Because B stands for biceps, another B for brachialis, and the C for coracobrachialis. There is not that much of an important clinical application, apart from the fact that anytime you rupture the musculocutaneous nerve, there will be a pop eye sign. So that's about it. I do have a picture of what the pop eye sign looks like after the tendon rupture of musculocutaneous. This is what it looks like. So yep, this was actually asked in NEET 2019, this picture, if I remember correctly. Yep. Okay, anyways, but it's not very important, not as important as the other nerves that we're going to discuss. Coming to the axillary nerve. Axillary nerve has two main functions. It supplies the deltoid and the teres minor. So remember we spoke about supraspinatus and how it helps in the first 15 degrees of abduction. Deltoid acts on the 15 to 90 degree of abduction of the arm, and teres minor is mainly for external rotation of the shoulder. It's not very essential. So I told you I'll discuss all the degrees of abduction with you because I think this is quite high yield. So in abduction, the first 15 degrees is by supraspinatus, like we already discussed. 15 to 19 degrees is by deltoid, and more than 90 degrees it's by the trapezius muscle. So that's it. This is, again, they keep asking questions in this. It's quite important, and I think I have a picture for that. Yep, So coming to this, so this, just imagine this this to be the first 15 degrees, maybe till here. This is the supraspinatus. Then the 15 to 90 degrees is taken care by deltoid, and above 90 degrees, that's overhead abduction, is taken care of by trapezius and some other additional muscles. So that's about it. That's all you need to know about the axillary nerve. Again, an important nerve. So yep, coming to the median nerve. Okay, median nerve, you can just remember it as middle. So what do we find in the middle of a sandwich or a hamburger? We find the meat, but okay, we use two loaves around whatever is in the middle. So this will be our mnemonic: two loaves, 2L for the first two lumbricals, O for opponens pollicis brevis, A for abductor pollicis brevis, AB ductor, and then F for flexor pollicis brevis. All these pollicis means it's going to the thumb, the supply. The thumb is the police guy of our hand. Just remember it like that. And all of these are there in the thenar eminence. So this part of our hand is a thenar eminence, which is mainly supplied by the median nerve. This is the hypothenar, which is supplied by the ulna. So that is important. Okay. So what is the applied part of this? The main thing here is carpal tunnel syndrome. So what is carpal tunnel syndrome? Carpal tunnel is, I'll just tell you, carpal tunnel is basically this tunnel which is existent beneath the flexor retinaculum. It's here. If I take a cut section of this, this is what it looks like. So there are many, there's like a compartment beneath the flexor retinaculum. I'm not going into the detail, but this right here is the nerve. So whenever there is an inflammation of this space, there will be intense pain in this entire hand, and they'll complain. The patient probably will come with complaints of pain in all of this area. Probably they are typists, or even in conditions like pregnancy and hypothyroidism, where there's pressure on the wrists, or even drivers sometimes, they come with those complaints. And medial nerve also supplies a lot of flexors. I won't go into that. A lot of flexors of the hand. So that's what happens in carpal tunnel is that there's this tingling numbness of the first 3.5 fingers. So I'm talking about till here. So I'll show you a picture of that. Yep. So this is the median nerve supply. This is beautifully given. This is this part, as you can see, it's the lateral portion of the hand, but 3.5 digits. So they'll have even the dorsal portion, but only the proximal part of the dorsal, fingers, because the rest of it is, as we'll know, like the rest of it is supplied by the radial and the ulnar. So we'll discuss that later. So this is about it. Now, what if there is a palsy of the median nerve? If there is a palsy of the median nerve, they get something called the hand of benediction and the hand of Pope. This has also been asked. So this looks a lot like an ulnar claw hand, but it's just not that clawed. I don't know how else to put this. Coming to the radial nerve. So this is my favorite nerve. It should be your favorite nerve. It's the best nerve in the world. So this is a mnemonic for the radial nerve. It is the best. Okay, why best? Because it supplies the brachioradialis, the extensors of the hand, the supinator, and the triceps muscle. Okay. So triceps, we all know, biceps causes flexion, triceps causes extension. In the anatomical snuff box, that's right here, this is the anatomical snuff box, there's a superficial branch which basically gives nerve supply to most of the dorsal aspect of the hand. It also supplies in the arm the dorsal aspect. The dorsal aspect is mainly taken care of the radial nerve. So there is two types of palsy, which is very important. Actually, there is quite a lot of detail to the level of injury, because different levels in the hand or arm will cause different types of injury. But I'll cover the two main ones right now. I'll probably do a different video for radial nerve because it's a very high yield in every exam, including NEET, PLAB, USMLE, you name anything, hand nerves, these arm nerves are very, very important. So, you know, it's worth investing some time, because this topic is highly volatile. Although I've studied it multiple times, it's still a very volatile topic, so we're prone to forgetting. So it's a good idea to learn this properly. Anyways, there's something called crutch palsy. You know how a crutch looks, and this was usually in the olden days type of crutches, where they used to completely put it inside the axilla and lean on it. Nowadays we have better crutches, but obviously. So what the patient will have is they'll have a wrist drop, and also the triceps will be affected if it's at the level of the axilla. That means there'll be loss of arm extension. So compare the fracture of the radial groove of humerus. If the fracture is of the humerus, there will be only wrist drop, and the extension will be preserved. So why is this? Because the radial nerve actually gives a branch to the triceps in the axilla itself. So if there is a fracture beyond that branch, then obviously that nerve supply will be preserved. That's what I'm trying to say, because it's already given that branch, so it's triceps is already getting innervated, so it's not going to be affected if it's the fracture of the radial groove. We've learnt about the radial nerve, we've learnt about the musculocutaneous nerve, the median nerve, the ulnar nerve, and I actually had a picture of the BBC muscles. Yep, this is a beautiful picture. You guys remember BBC, which is BBC, the most muscular channel, that is the musculocutaneous nerve. This is the BBC. So they've removed the biceps. So beneath the biceps, you have the brachialis here. The biceps has two heads, short head, long head, all that stuff. You guys go and have a look at all that. Okay, yeah, I actually missed out two of these things in the medial part. That is the medial brachicutaneous nerve and the medial antebrachicutaneous nerve. These two are not at all clinically relevant. They just supply, it's basically the medial nerve of the arm and medial nerve of the forearm. That means it just gives like cutaneous supply to, you know, the medial portion of the arm and the forearm. That's about it. Coming to the ulnar nerve. Okay, so about the ulnar nerve, this is again an important nerve. It gives supply to 75% of all the muscles in the hand and the last two lumbricals. So the first two lumbricals, you guys remember, median nerve, two lobes. I hope you guys remember that. Median nerve is crushed between two lobes, so that gives the first two lumbricals, 2L, two lobe. This gives the last two lumbricals, and it supplies the hypothenar muscles. So another thing is it supplies the interossei, very, very important. So the best way to, there is a palmar and a dorsal interossei. Palmar interossei AD ducts, so pad, and dorsal interossei AB ducts, so dab. There is the ulnar claw hand. I showed you that picture before, and I told you not to confuse between that. So this is the hand of benediction, this is the claw hand, this is the ulnar claw hand. Okay, and also if there is, see how in this case he's unable to extend these two fingers all together. Sometimes there is median and ulnar nerve together, and that's called complete claw hand. So this is a complete claw hand, whereas this is just the ulnar claw hand. Okay. Okay. A little bit about the root injuries. Yeah. So a little bit about the root injuries. I'm not going into detail. I'll make a different video if time permits. Whenever there's a root injury at C5, C6, C7, it can happen every time. Think about a situation in which a baby is coming out of the mother's body, and you have a very inexperienced gynecologist probably just tugging at the hand, you know, hyper abducting the arm away from the shoulder. For example, imagine a guy is falling from a mountain and he catches hold of a branch, you know, that kind of hyper abduction. Then you'll have something called Herb Duchenne's palsy. So in that case, they'll have something called the waiter's or policeman's tip. This happens when there's injury at the Herb's point, which I'll discuss about in my next video. And then the lower root values at C8, T1, You get Klumpke's palsy, or that's another type of palsy we'll discuss. And how to remember these: the upper root injury causes herbs and the lower root injury causes Klumpke's. E comes before K. Just remember that. So herbs and Klumpke's palsy. So before wrapping it up, this is the whole thing. I hope it's somewhat clear. I tried my best to at least wrap it up a little fast. So just a quick recap of the pictures alone, because they're quite high yield. So this is winging of the scapula. This is the serratus anterior, which nerve supplies long thoracic nerve. This is the suprascapular nerve, and this is the pectoralis major muscle. I told you about the hug, everything. This is the latissimus dorsi. We learnt about this. This is the Popeye. Just have it in mind. This is BBC, supplied by the most muscular TV channel. It's musculocutaneous nerve, 3 muscles, BBC. This is, I told you, the different levels of abduction. If you like this video, please like, share, subscribe. I'll try to be more regular on my YouTube channel, because now I have a little bit more of time, and I'm also preparing for an exam, so I'll be sharing all the topics which I think is challenging on a student level. Anyways, thank you so much. Bye bye. Until next time.